we are studying circulating tumor cells or CTCs as an alternative to the bone marrow aspirates. Up to now, the gold standard for tumor evaluation are the bone marrow aspirate. By his highly invasiveness, is a limitation to monitor correctly the patients. We think that the CTCs are a non-invasive alternative that could be help us to redefine the current staging systems, also incorporating the tumor burden itself. For that, we are collecting patients along the disease evolution, smoldering patients are treated, are untreated, an observational study, newly diagnosed patients, transplant-eligible and transplant-ineligible patients, and relapsed patients along different clinical trials from Spain. And the idea is to evaluate CTCs in all these patients and try to study the dynamics of CTCs along the disease evolution. And we showed that CTCs are detectable in most patients, and moreover, the numbers are correlated, are highly associated with other risk factor diagnosis, such as ISS, the classical stratification systems, or the 2020 model in smoldering patients. So there is a strong correlation with risk. Moreover, we also calculated clinical cutoff for make more straightforward the clinical application. And we showed, for example, that patients with smoldering myeloma with high CTC levels, above 0.02, had ultra high risk transformations. And with these patients with smoldering myeloma were early intervened, this high risk will totally abrogated. Regarding newly diagnosed patients, we found 3 groups according to the undetection of CTCs and the presence of CTCs below and above 0.2. Those patients with 0 CTCs, with no detection of CTCs, have an exceptional outcome, and those patients with more than 0.2 CTCs define a group with a very dismal PFS. Moreover, those patients with relapsed multiple myeloma, the presence of more than 0.2 CTCs point for a group with less than 6 months of survival. That is very remarkable. Moreover, we investigated the clinical value of CTCs according to the depth of response, and we see that only the achievement of MRD, the minimal residual disease, was able to remove this bad prognosis. The complete response was not able to remove this value. And we also compare the bone marrow and the peripheral blood from a transcriptomic point of view, and we found that the transcriptional profile were highly overlapped. We only very few genes differentially expressed, but these genes also were unstable along the disease. So we are trying to find different patterns and his biological relevance, trying to identify targets to avoid plasma segregation from the bone marrow and disease spreading. I think that CTCs could help to improve a bit more the current stratifying systems, taking account a more direct assessment of the tumor burden. And specifically, I say that the low invasiveness is a clear advantage for a closer follow-up of these patients. In my opinion, a nice example will be the CESAR trial. The CESAR trial is the trial when we early intervene those patients with smoldering myeloma. Those patients that in the untreated group with high CTC levels, this group lose his bad prognostic when early intervened. I think it's a very nice example to do that. This scenario is very controlled because we are working with clinical trials. We wanted to, in a future, maybe not so far, to expand this study, incorporating new patients in the daily routine of myeloma diagnosis, trying to work in a more in a more real scenario, not so controlled. And I would like to also say that I am really the peak of the iceberg. This work is realized in a very big group, and we worked very hard to cure the multiple myeloma through, in this case, through the circulating tumor cells.